Hi. Welcome back. And today I'll be discussing case number 2 in our approach to significant but poorly localized abdominal pain. So, this is again be a clinical vignette, and then we'll discuss the imaging relevant to this particular case before expanding to the imaging of chronic pancreatitis in general. That is autoimmune pancreatitis vis-a-vis chronic pancreatitis. So, our case is again a 57-year-old gentleman who's been detected to have diabetes mellitus 8 months back. He is poorly controlled on SGLT2 inhibitors and has no microvascular or macrovascular complications. He's been screened for the same elsewhere. There's no history of substance use or abuse, and now he's presented with loose stools for the last 6 months. There's passage of 2 to 3 semi-solid stools per day, which are described by the patient as having an oily consistency and are difficult to flush. They resolve with prolonged fasting and worsen a few hours after ingestion of meals, particularly ingestion of oily foods. There is, however, no associated passage of blood or mucus or in the stools or any other rectal symptoms. Importantly, the abdominal complaint is there, but it is a secondary complaint for this patient. It is gradual in onset, persistent, deep-seated, but poorly localized, dull aching, mild to moderate in severity, and there's no radiation of abdominal pain. Now, it would seem slightly arbitrary that I have put the abdominal pain as a secondary complaint and the loose stools as a primary complaint here. But again, when you talk to a patient, what the patient feels is their primary complaint is the primary complaint. So the thing is that abdominal pain here is mild to moderate in severity, and because of that, the patient is not significantly perturbed by it clinically. And finally, the aim of a medical diagnosis is to relieve the patient's symptoms. So, the second complaint that the patient has, a third rather, associated complaint is an unintentional weight loss over the last 6 months. He's lost over around 10 kgs over the last 6 months without any difficulty in chewing, swallowing, any anorexia, early satiety, or other B symptoms like fever or drenching night sweats. He also has noted generalized pruritus over the last 6 months, which has been episodically worsening. It is generalized without any, distribution in a photo distributed area. There's no photosensitivity and there are no features of atopy. Importantly, there is no history suggestive of nocturnal episodes of passage of loose stools, again implying that it's a malabsorptive diarrhea, GERD, or epigastric discomfort. Features suggestive of fat soluble vitamin absorption of pedal edema, anasarca, or vomiting are also not there. So we have a case of malabsorptive diarrhea with poorly localized but significant, although not as significant as the loose stools, abdominal pain without vomiting. Okay. Now on examination, the patient is importantly icteric. There is jaundice. However, there are no other features of fat soluble vitamin malabsorption. Vitals are within normal limits. The abdomen is soft. There is no hepatosplenomegaly. There are no masses palpable. An investigation is then done outside. Showed a total bilirubin of 5.6 and direct bilirubin of 3 milligram per deciliter. So with an slightly elevated ALP. So again indicating an obstructive jaundice. So we've already discussed the diagnostic framework for steatorrhea in the previous case vignette in the series. So this is again the same thing because the patient has steatorrhea. Now what we can say quite clearly is that the patient does not have epigastric discomfort, does not have any features suggestive of GERD. So Zolligan-Ellison syndrome is highly unlikely. The second thing is there is prominent pruritus. There is biochemically confirmed obstructive jaundice that is not compatible with a wall abnormality within the GI tract or a lymphatic obstruction. So as of now, it becomes less likely, although we can't completely rule it. So the other three differential diagnoses are still very valid. So the patient could have a intra or extrahepatic biliary tract obstruction, and I've discussed the approach to this in an approach to abdominal pain due to distension of parenchymal organs. So you can have a look at that. The patient could have a loss of ileal absorptive function. That is, obviously, there's no resection in this patient. So, due to, say, Crohn's disease and ileal tuberculosis, and a patient with Crohn's disease also could have obstructive jaundice due to, say, coexistent primary sclerosing cholangitis. Finally, the patient could just have a case of chronic pancreatitis. However, importantly, that doesn't really explain the obstructive jaundice. So, again, on face value, we can sort of say that it is not chronic pancreatitis unless there is something else to, suggest an alternate pathology. And naturally, as we've discussed the pathophysiology and the clinical presentation of autoimmune pancreatitis, this could be chronic pancreatitis if it is autoimmune pancreatitis. Okay, so these are the three differentials that we would entertain. So again, the putative etiology would become obstructive jaundice, say due to a periampullary mass or primary sclerosing cholangitis. It could be Crohn's with primary sclerosing cholangitis coexisting together. I put that as a second differential because again, that would be two separate, although linked pathologies, and therefore two separate things in the same person have a slightly lower risk than one single pathology. And it could be chronic pancreatitis as long as it is autoimmune pancreatitis. Okay. So the syndromic diagnosis, as I've discussed, is steatorrhea with obstructive jaundice with features suggestive of significant but poorly localized abdominal pain, but see, without vomiting. But importantly, it's mild. It's not the primary complaint. Recently diagnosed diabetes mellitus without any complications of long-standing diabetes mellitus, implying that they may be related, that the pathology may be what is causing the diabetes, and unintentional weight loss. Now, even in the presence of an obstructive jaundice, this really doesn't really change our differential diagnosis. It doesn't favor one or the other because all three pathologies here can cause obstructive jaundice by one mechanism or other. So we send serum biomarkers because again, just epidemiologically speaking, malignancies are much more common than IgG4 related disease and autoimmune pancreatitis, and even Crohn's in a patient who's this sort. So we get the reports back. CA 19-9 is normal. So okay, there's no extrahepatic biliary apparatus mass. The CA 125 is elevated. This is a male patient. That's a little odd. Serum carcinomembryonic antigen is elevated, around 1.5 times upper normal limit. Now, why was CA 125 done? Primarily because the peritoneal pathologists can also have elevation in CA 125. It's not only specific for ovarian malignancies. So in males also it can be assessed, and as you can see in this particular case, it is elevated. Importantly, IgG4 levels are elevated 3.6 times the upper normal limit. So the thing with this is that, as we've discussed in our approach to or the clinical presentation and pathophysiology of autoimmune pancreatitis, elevation more than 5 times is what we consider significant, but and less than 2 times would be insignificant. So 3.6 puts us in the borderline area. It could be explained by the other two differentials as well. Okay, so serum carcinomembryonic antigen and carcinoma antigen 125 levels need to be interpreted. So before we go ahead, we'll just talk about that. Both are measured using immunoassays, and carcinomembryonic antigen is actually a highly glycosylated cell adhesion molecule that is expressed by GI epithelial cells, and this is primarily produced during fetal life, but production also happens in adults at very low levels. The normal serum levels are usually 2 to 4 nanogram per ml. On the other hand, CA 125 is a highly glycosylated hydrophilic protein that adheres to water, being hydrophilic, and functions as a to maintain the barrier function at the female at three sites. That is the female genitourinary tract, the mesothelial linings of the pleura, the peritoneum, and other mesothelial line structures, and within the conjunctiva and cornea. So as you can expect, these are used as markers. CAA is used as a marker for gastrointestinal tract adenocarcinomas, particularly colonic, and higher levels correlate with liver metastasis, peritoneal metastasis, and a more differentiated tumor. Ovarian CA 129 is primarily used for genitourinary tract malignancies, but can be elevated in other malignancies as well because of the diffuse expression in in a normal patient. Now, the issues with the sensitivity and specificity is too low for use clinically in other malignancies where these things can be elevated, but they are important to keep in mind when you send them. So CAA values can be elevated, but are not clinically useful for diagnosis in case of non-small cell lung carcinomas and medullary thyroid carcinomas. Similarly, CA 125 is elevated in, I use a mnemonic for this, pebbles, that is pancreatic, E for endometrial, B for breast, L for lymphoma and lung malignancies, E for epithelial GI malignancies, and squamous cell carcinomas of the vagina or the cervical epithelium. Finally, there are other causes of false positivity other than for malignancies also. So CAA can be is metabolized by the liver, so it can be mildly elevated in any form of hepatic dysfunction, including obstructive jaundice. That would be relevant in our case. It is elevated in cases of hypothyroidism in smokers, and there is something called a carry-over effect, which is a lab problem. As in, if the wells are not cleaned during subsequent cycles of running the test, you may have a false positive in a subsequent test. Similarly, there are some cheap false positives for CA 125. CH stands for cirrhosis, again for the same reasons as for CA. E stands for endometriosis. AP stands for acute pancreatitis, peritonitis, and pelvic inflammatory disease. And finally, P stands for pregnancy. So this is not something that you should send during pregnancy. This in the first trimester of pregnancy, it is elevated in about 1.6% of normal adults. Now, false negatives, naturally, both being immunoassays, could be false negative due to prozone. That is because the antibody titers are so high, they are interfering with the test. And in very poorly differentiated GI tumors, they are obviously they're not able to produce CA properly. So as a result, this false negative. Okay, so thus this leaves us in a very precarious situation. The serum IgG4 levels are elevated, but they're only elevated 2 to 5 times the upper normal limit. So autoimmune pancreatitis, as we've discussed previously, related to IgG4 related disease, typically has levels more than 5 times the upper normal limit. Serum CA levels are elevated, and CA 125 levels are also elevated. They, as we've just discussed, have multiple other causes. Uh, So these are primarily intended as screening tools and are not particularly useful to us in this clinical context. So we are left with the same question again. Is this an obstructive jaundice, maybe due to a malignancy, say a periampullary carcinoma of the pancreas, or other cause? Now we are reasonably sure that the biliary tract is not affected since the CA99 levels are normal. But again, that again depends on the differentiation of the tumor, and that is a discussion for another day. So what do we do? Imaging? Yes, but the reason for this is actually slightly interesting. The reason is that autoimmune pancreatitis has some characteristic clinical imaging findings, or radiographic imaging findings that help us say with reasonable certainty that it is actually autoimmune pancreatitis and not a pancreatic mass that we're dealing with. So that brings me to the second part of the this screencast. That is, I'm going to talk about autoimmune pancreatitis versus pancreatic adenocarcinomas and how we use imaging to differentiate focal lesions caused by these two entities. Then we'll talk about enhancement patterns, naturally in case of autoimmune pancreatitis being that of fibrosis. We'll talk about how storiform fibrosis may trap islands of normal pancreatic tissue. Malignancy naturally would not do this. And we'll talk about two signs, the penetrating duct sign and the duct cutoff sign, both specific. And then we'll formalize the imaging findings and how they are utilized in differentiating autoimmune pancreatitis versus neoplastic mass lesions. Uh, we'll talk about what is the most specific imaging finding and what is the most sensitive imaging finding in this particular radiological differentiation of these between these two different entities. Getting right into it, autoimmune pancreatitis versus pancreatic adenocarcinoma. So, as we've just done previously, we know that in autoimmune pancreatitis there is storiform fibrosis within the pancreatic mass-like lesion. So they will naturally show a fibrosis-like enhancement pattern. So in autoimmune pancreatitis, you have a delayed contrast enhancement of the pancreas or the tissue that is in the lesion. Whereas in pancreatic adenocarcinoma, the enhancement is actually more than normal pancreas or equivalent to the normal pancreas. In there are because of the nature of the fibrosis, the storiform fibrosis, in normal areas of pancreas can get trapped within this fibrosis, within the fibrosis caused by this lesion. So you get islands of normal early enhancement, and no delayed enhancement trapped within a mass with delayed enhancement. So again, this is very specific for type 1 autoimmune pancreatitis. Storiform diffuse fibrosis without parenchymal contraction is again a characteristic of autoimmune pancreatitis, as in there is fibrosis but there is no volume contraction. Okay, so as a result, what happens is that the pancreatic duct, as it passes through the lesion, it doesn't really get dilated, it doesn't get distorted, nothing happens. So that results in something known as the penetrating duct sign. A malignancy naturally would infiltrate the duct or compress the duct due to mass effect, and that causes a duct cutoff sign. And finally, you can get storified fibrosis around the duct itself, resulting in an enhancement of the duct. This is a relatively uncommon finding, so it has a lower sensitivity, that is only 36%, but the specificity is 98%. So that would result in an LR positive of 18, odds of 18. Okay, so that's very significant. Pancreatic adenocarcinoma, the duct is not uniformly at least enhanced. It can show patchy enhancement in areas where the malignancy is infiltrating the duct. So let's see what this looks like on images. Autoimmune pancreatitis enhances like fibrosis. So we get mass-like enlargement of the head and neck of the pancreas. Again, could be a mass, could be a malignancy. Um, in the arterial phase, we see low enhancement as compared to the rest of the gland. And in delayed phase, we see hyper enhancement. So this is the arterial phase and this is the delayed phase. So as you can see, this is the mass lesion. I've highlighted it in red. In the arterial phase, you see that the normal gland is hyper enhancing, whereas in the delayed phase, it is the mass that is hyper enhancing, indicating that the mass is consistent of fibrous tissue. Um, in the image in the lower half of the section, we see the characteristic sausage-like enlargement of the body and tail of the pancreas. The arterial phase enhancement is very well appreciated in the pancreatic head and uncus here, whereas the pancreatic mass is not enhancing. Okay, so it will probably enhance later in a delayed phase image. So again, these two are highly specific and help in differentiating quite easily. So this is the mass, and it is showing decreased enhancement as I've shown. Now, second is islands of normal pancreas get encased within the fibrosis. So again, we have arterial phase axial images and arterial phase coronal images. In arterial phase, we expect the normal pancreas to enhance very well, whereas fibrosis to enhance poorly. So what we see is we see islands of normal early enhancement without any delayed enhancement within the lesion. So those are shade. I'll just show you. They're highlighted with the arrowheads, and I'll shade them red. Now there is also a typical band-shaped structure demarcating the lesion, that is the capsule of the lesion. Okay, so these red areas are actually the islands of normal pancreatic tissue that have gotten trapped within the lesion. I just highlighted a few of them. And the blue is actually the rim of the lesion, which is consisting of fibrosis and therefore is not showing adequate enhancement. So again, in the coronal section also, it is the same. This is the rim, and the red is the islands that have been trapped. So again, very characteristic, cannot happen in a malignancy. If you see this is autoimmune pancreatitis. Okay. Now, next is the penetrating duct sign. Again, penetrating duct sign is indicative of an inflammatory mass. So on the left side of your screen, we have an axial T2 weighted haste image, which is a rapid acquisition sequence, as I have discussed previously, to decrease motion artifact. So as you can see, within the lesion, you have a duct. Since this is a T2 weighted image, the fluid filled structures are bright. So you see a fluid filled structure here, and this is actually the duodenum with the star showing the papilla vater. So as you can see, the duct is patent within the mass and it is opening as a papilla vater, indicating that obviously this patient has an inflammatory mass. On the other hand, this is an axial titubated haste image of another patient where you can see the duct dilated and it's abruptly stopping at a particular point. So this is known as the duct cutoff sign. This courses up to a patent duct courses up to the head of the mass in the head of the pancreas and is suddenly cut off. So that is the duct cutoff sign, highly indicative of a pancreatic neoplasm. So in summary, autoimmune pancreatitis, depending on the clinical presentation, may need to be differentiated from pancreatic adenocarcinomas and other neoplastic lesions within the head of the pancreas. And imaging plays a vital diagnostic role in this clinical context. So we'll formalize this a little bit more. While comparing parenchymal versus duct findings in differentiating autoimmune pancreatitis from pancreatic adenocarcinoma, a parenchymal finding actually has the highest specificity. So the presence of a peripancreatic rim, that rim of delayed enhancing tissue showing delayed enhancement, is actually has the highest specificity, pooled specificity approaching 100. Okay, so it's almost pathognomic. On the other hand, it is a duct finding which has the highest sensitivity. So if you see lack of duct dilatation proximal to the lesion, okay, that is upstream of the lesion, it indicates that the duct is not getting compressed within the mass. So that is highly sensitive for a inflammatory mass lesion vis-a-vis pancreatic neoplasms with a sensitivity of up to 96%, but pool sensitivity of 87%. So these are the two findings that have the greatest clinical validity. Now, what we've discussed in this screencast was we compared autoimmune pancreatitis to pancreatic adenocarcinoma, presenting as focal lesions within the pancreatic parenchyma, obviously resulting in some confusion. We've seen how enhancement patterns help us differentiate the two. We've shown how in autoimmune pancreatitis, storiform fibrosis can trap islands of normal pancreatic tissue, and a malignancy naturally would not do this. And we've discussed the penetrating duct sign versus the duct cutoff sign. We've determined how to choose between MRI and CT in cases of suspected autoimmune pancreatitis versus pancreatic neoplastic lesions. Specifically, we've talked about the sensitivity versus specificity of these two findings. So that is the higher, more specificity is with the finding that is your. So we've discussed that the highest specificity is with the. Okay, so we've also formalized the imaging findings and their utility in cases of suspected autoimmune pancreatitis versus pancreatic neoplastic lesions. So we've determined that the most specific finding is actually the most specific finding is actually the peripancreatic rim, and the most sensitive finding is the lack of upstream dilatation. Okay, that is based on pooled specificity and sensitivity. Now, finally, before we finish, what if imaging shows no evidence of extrahepatic biliary obstruction? What if chronic pancreatitis itself is what you find on the imaging, and that explains all of the clinical presentation of the patient. So, in this situation, one may need to differentiate autoimmune pancreatitis from other forms of chronic pancreatitis. So, this would be a patient in which obviously the jaundice was not this prominent. Imaging again plays a vital diagnostic role in this clinical context, and that is what we'll cover in the next video. So I'll see you then, and we'll discuss the details of this clinical scenario in that video. Thank you for watching. I'll see you next time.